Okay.
All right, people are starting to join us. Hi, everyone. We'll wait just a few more minutes and wait for everybody to join us. If you don't hear us, well, then you don't hear us. All right, we have about a couple minutes before we get started, everybody. Hi, Doherty's. The Doherty's figured out the chat button. If anyone wants to talk during this webinar presentation, there is a Q&A button and a chat button. So, hello.
I hit the chat. Uh-oh.
All right, we're just going to give it just like maybe 1 or 2 more minutes, and then we'll kind of let everybody. Oh, Linda says, I guess, I don't know which Linda it is. Thanks for presenting this evening, Deb.
Oh, you're welcome.
All right. You want to give it 1 more minute before we get started?
Yeah, that's fine. It looks like you're on vacation in Italy, Christine.
Well, this is our lanai, or the lakeside terrace.
I know, it looks beautiful. You look like you're on vacation.
Well, we'll go ahead and get started, and anyone who can join will join later. I'm just gonna do a couple of housekeeping. So this is a webinar. It's not like most of our Zoom meetings and Zoom events have been in the past. So if you want to ask Mrs. Reichel a question throughout the presentation, then you can just click on the bottom of your screen. There's a little Q&A button, and you can type in your question. And please type in your name first, because it might pop up as your phone number. And that way, at the end of the webinar, we can ask the questions and get some really good information. Our featured speaker tonight for our Let's Have a Heart-to-Heart conversation is Hampton Hall resident, Mrs. Deborah Richeal, and she is a National Registry Paramedic and EMS Educator with over 25 plus years of clinical and educational experience as a flight paramedic overseas. She was a paramedic in Trenton, New Jersey, taking 911 calls and special care transports. And she is an emergency medical services educator, training doctors, nurses, paramedics, EMTs, and laypersons in American Heart Association CPR, advanced cardiac life support, pediatric advanced life support, and several others. We're so grateful to have you, Mrs. Reichel, presenting this material to us. Thank you. And we're
Thank you. And thank you for everyone that is joining us this evening. I tried to make this presentation fun. I actually wrote it just for this presentation for Hampton Hall. And I wrote it in the evenings and on the weekends in between working. But I wanted to make it informative and fun at the same time. So I hope you gain a lot of information out of it, and also finding it a little entertaining at the same time. I have a little bit dark sense of humor for being a paramedic for 30 years, so bear with me. So we're gonna get started here. And again, thank you for your time this evening. So let's talk about some of the objectives for this presentation. We're going to talk about the many functions of the heart. The heart is really an incredible organ, and it works independently from the brain. It has its own electrical system that you're going to learn about, and it's really just it's a surviving organ. It does everything it can to survive. We're going to talk about the causes of chest pain. We're going to talk about the signs and symptoms of a heart attack, or in medical terms, a myocardial infarction. How these symptoms vary in men versus women. We're really weird when we're having a heart attack. Our symptoms are very different, so I'm going to talk about that. We're going to talk about cardiac arrest, what to do in cardiac arrest, and knowing CPR, why it's important to know it, and it's just a good skill to have, because you never know when it's going to happen or where it's going to happen. And we're also going to talk about the mechanics of good CPR compressions, how to do CPR compressions, how an automated external defibrillator or an AED works on the body. And we're going to talk specifically about the AEDs that are here at Hampton Hall. We have what is called Zoll AEDs here, and I have a little video of how the AEDs work here in Hampton Hall in case we ever have to use them. Hopefully we don't ever have to use them. And then at the end, we'll have a little Q&A. And just to put it out there, I'm not a doctor by any means. People come to me in my classroom all the time at the flight safety building with medical questions. And one of the first things I say to them is, I'm not a doctor. So hopefully, I'm just going to impart some of my wisdom to you that I've learned over the last 30 years of being a paramedic. And I love to share this information because it's really important. And don't underestimate what you're learning tonight. It's really important information, and you may be using it someday, either for yourself or for your loved ones. So if everyone can grab a piece of paper and a pen. I don't know if you have paper and pen handy. I'll give you a couple minutes to do that, or make sure you got some paper and pen, because I'm going to ask you some questions about the heart to see what you know about it. And then I'm going to put up some slides with the answers on them to see what your knowledge is about the heart. So maybe Christina, you can, maybe through the chat, everyone can let us know when you're ready to answer some questions. Give you a minute to grab some paper and pen. People coming into the chat, so hopefully some of you are ready.
The Najum family is ready.
They're my neighbors.
And Miss Tanya and Mr. Odell.
All right.
Mrs. Neal. Mr. Spears.
And I apologize, I will be drinking some water throughout the presentation. I've been teaching since 7:30 this morning, so my voice is a little dry. All right, how are we looking? Everybody ready to write?
Yep, we've got a lot of readies.
All right. All right, so I'm going to start asking you a few questions here, and you can just, take a wild guess. If you don't know, that's okay. And so the first question is, what is the average time that your heart beats in 1 minute? What do you think the average resting heart rate is in an adult? So on that piece of paper, I want you to write down what the average times per minute or beats per minute that your heart beats in a minute. How many times does it beat in a minute? And then I want you to write down how many times you think it beats in a day. So you can use the calculator on your phone if you want, or you can just estimate. This is just kind of for fun to see what you know about the heart. How many times, the third question is, how many times does it beat in a year? How many times do you think your heart beats in 1 year? And the next question, how many times do you think your heart beats in your whole lifetime? Your whole lifetime. And I know that can differ from person to person, but usually we'll say an average of 75 to 80 years. And the next question, how many gallons of blood do you think your heart pumps to the body in 1 day? How many gallons of blood do you think are pumped through your body in 1 day by the heart? How many gallons a day does your heart pump throughout your body? And 2 more questions. The next question is, how big do you think your heart is? How big do you think your heart is? What could you compare it to? The size of what? How big do you think your heart is? And the last question, how many chambers do we have of the heart? How many chambers are in the heart? How many chambers? I know that was a lot of questions. All right. I'm going to reveal the answers. Here we go. So on average, your heart beats about 72 times in a minute. And you can compare your answers to the slide here. It beats about 100,000 times a day. 3,600,000 times a year. 2.5 billion times during a lifetime. That could be 2.5 to 3 billion, depending on how long you live. Your heart also pumps about 2,000 gallons of blood through 60,000 miles of blood vessels each day. That's pretty incredible if you think about it. Your heart is small. It's about the size of your fist. And that little heart is pumping 2,000 gallons of blood a day through your body, through 60,000 miles of blood vessels. Also, as I said earlier, your heart has its own electrical impulse. So it has nothing to do with your brain. Some people think that the brain stimulates your heart to beat, and they really don't have anything to do with each other. The heart has its own electrical system contained within the heart muscle, and it can be even separated from the body as long as it has adequate blood supply. And that's what makes it capable of us doing heart transplants, that we can keep the heart alive. As long as it has oxygenated blood supply, it can beat on its own. It doesn't have to do anything with the brain at all. All right. How did you do on that test, by the way? How did everybody do with those numbers? Were you close? Put it in the chat. I'll have Christina look at it. Let me know if you were close with any of those numbers. I know some of you were probably close because I know some of you have medical background. All right. So as I said, the heart is the size of your fist. It's divided into 4 chambers, 2 atrium and 2 ventricles. So we know that's approximately the size of the heart. It lays just to the left in the chest cavity. And so when we're born, our heart is really tiny, and it's right below our sternum when we're infants. And as we grow older, The mediastinum, which is the area inside the chest cavity where all the major vessels are housed, pushes the heart over slightly to the left. So by the time we reach adulthood, our heart is slightly to the left in our chest cavity, and our lung on the left side only has 2 lobes, but our lung on the right side has 3 lobes, because on the left side, we have to accommodate some room for the heart. So that's why our lung on the left side only has 2 lobes in the left lung. I'm going to play this National Geographic video. It's a short video I found on YouTube. I thought it was really good to explain the circulation of the heart and how the heart pumps blood out every day and how it works. It's going to be loud, by the way. I have my volume up all the way so you can hear the videos. So you might want to adjust the volume on your computer. If it comes over really loud, you can adjust the volume on your computer.
The heart pumps blood throughout the body, carrying oxygen and nutrients to every cell. It's this circulation of blood that is vital to sustaining life. The heart is an organ made up of several tough layers of muscle. The pericardium is the thin layer that covers the exterior, while the endocardium lines the inside walls. The heart is divided into 4 chambers, 2 upper and 2 lower. The upper chambers, known as the atrium, receive blood coming into the heart. The lower chambers are the ventricles that pump blood out. Between each chamber are valves that open and close and help keep the blood moving. They are the tricuspid, mitral, pulmonary, and aortic valves. A pumping cycle starts when oxygen-depleted blood returns to the heart after circulating throughout the body. The blood enters through the right atrium before flowing to the right ventricle. It's then pumped to the lungs via the pulmonary arteries. There, blood is rejuvenated by air that's breathed in. The oxygen-rich blood returns to the heart through the left atrium, where it goes to the left ventricle. Then, by way of the aorta artery, the fresh blood is pumped throughout the body before the process repeats itself. That process happens with every heartbeat, and it's relentless. The heart beats 100,000 times a day, 40 million times a year, and up to 3 billion times over an average lifespan. But there are conditions that can disrupt a heartbeat and that normality. They can range from myocardial infarction or a heart attack to heart disease and hypertension. In contrast, exercise and emotional excitement can also have an impact on a person's heartbeat. The various blood vessels that comprise the circulatory system are a network of veins, arteries, and capillaries that span over 60,000 miles throughout the body, and the heart is the pump at the center of it.
All right. Give me a minute to transition. This doesn't transition very smoothly. All right, there we go. So, I hope you learned a little bit about the circulation there and how the heart pumps blood to the rest of the body, how it receives oxygen. It's actually a double-sided pump. So the right side of the heart receives unoxygenated blood from the lungs, pumps it out to the lungs where it picks up the oxygen, comes back to the left side of the heart where it pumps it out to the rest of the body. So even though the heart is one organ, it doubles as a double-sided pump, which is pretty interesting. So who and when was the first? I wanted to put some fun facts in here that I thought you might find interesting. And the heart and the circulation system has been studied for decades, going all the way back to Egyptian times even. And I thought that, you know, when I started researching for this, there was some things I learned about it. And when I was researching how individuals were trying to figure out how the heart works and how it's really the pacemaker of our body, why we faint, why our blood pressure gets low, just all kinds of interesting facts. So I picked out some that I thought that you might find interesting. So The first in 1929, and I thought this was pretty funny almost, that this German surgeon who he actually examined the inside of his own heart by threading a catheter into his own circulation through his wrist, through the radial artery. And he threaded it about 20 inches into his heart, and he invented the first cardiac catheterization. So what is a cardiac catheterization? When someone is having a heart attack, if we get them to the hospital in time, right away, they go up to the cath lab or the cardiac catheterization lab. And a procedure is done under fluoroscopy where they thread through your radial artery, almost like a transducer that goes up into the radial artery, and it follows the circulation of the heart, and they inject dye into the coronary arteries. So they look for blockages, because there's got to be a reason why you had that heart attack, right? Why is that muscle being deprived of oxygen? And once they get in there and they find those blockages, they try to determine how bad are these blockages, how many coronary arteries are blocked, and then what can we do about it to fix it? And one of the procedures is called an angioplasty. And the first angioplasty was actually done in 1978, and it was done in Lenox Hill Hospital in New York. And I'm going to show you a video in a minute about how an angioplasty is done. Some of the other facts I wanted to share with you: the first ECG, or first electrocardiogram, was invented in 1903, looking at how the heart electrically pumps. And we're very lucky to be living today, by the way, in the medical field, because now when we get a 12-lead ECG done, they put basically stickers like electrodes on your chest. Back when the first ECG was invented, the first electrocardiogram, they were actually needles that went underneath the skin. And that's how they captured the electrical activity, is by strategically placing needles underneath the skin. So thank God we don't have to get ECGs that way anymore, right? Now they just put stickers on our chest and we can just relax in the bed. We don't have to have all these needles stuck into us to see what our heart's doing. The first implantable pacemaker was in 1958. I actually thought it was going to be before that. To me, that doesn't seem all that long ago. And the first human heart transplant was done in South Africa in 1967. Unfortunately, the recipient of the heart only lived about 18 days, and then they passed away. And so there can be a lot of complications from a heart transplant. You're on a lot of medications so that you don't reject the organ. And I'm sure a lot of those medications were not around back when that first heart transplant was successful. I'm going to play this angioplasty for you. All right, this video. So when you go in for that cardiac catheterization, depending what they find, they might put a balloon in that coronary artery to open up the artery. They might put a stent in the coronary artery to open it up, to keep it open. Or if they go in there and they find that there's too many arteries that are blocked, you might have to go in for a procedure for open bypass surgery, where they actually take part of your femoral artery from your leg and they transplant it. They get rid of the diseased coronary artery and they replace it with part of the femoral artery from your leg, so that you don't have any more diseased coronary artery in your heart. So I'm going to play this video so you can see what the procedure looks like. It's all animated, by the way. I don't want to, I know not everybody has a strong stomach, so I tried to pick animation for most of the videos.
Coronary angioplasty, also called as the percutaneous transluminal or balloon angioplasty, is a treatment procedure to restore the blood flow in the narrowed or blocked coronary arteries caused due to plaques or blood clots. Most coronary angioplasty procedures last between 30 minutes to 3 hours. Once the patient is admitted, his heart is monitored and is given an intravenous sedative to relax the body. A needle is inserted through the wrist into the radial artery. A guard wire is then passed through the needle and is guided through the arterial system up to the heart. A flexible catheter is slipped over the wire and threaded up to the heart. This is monitored using a continuous X-ray imaging device called fluoroscope. At this point, the guard wire is removed and the tip of catheter is positioned to enter the coronary artery. A special dye is injected which allows the fluoroscope to take X-ray images of the arterial interiors and help in identifying the position of the block. This is called angiogram. Once the blockage is identified, a flexible guard wire is inserted into the artery vessel, followed by a balloon-tipped catheter over this wire to position itself at the site of the blockage. Rapid inflation and deflation of the small balloon pushes the vessel wall out, re-establishing the flow of blood in the artery. After the blocked vessel is reopened, the deflated balloon catheter is withdrawn from the artery. The same treatment procedure is repeated in the case of multiple blockages. Most patients may also receive a coronary stent, which is a small tube made of wire mesh designed to keep the artery open once it has been treated. A collapsed stent is placed over the deflated balloon catheter as it is inserted into position. When the balloon is inflated, the stent expands and locks itself into place. The deflated balloon and catheter are withdrawn, leaving the stent behind to hold the artery open permanently. Post-treatment, a pressure bandage is applied over the radial artery to prevent bleeding. One will need to lie down for several hours, during which signs of bleeding or chest pain will be monitored. The patient may either be discharged on the same day or after an overnight stay at the hospital.
All right, that's what angioplasty looks like. And my stepfather, who's 87 years old, has had 2 heart attacks, and hold on, let me get past that. And he has 6 stents. So he's been very fortunate because my mother got him to the hospital in time, both times, for both of his heart attacks. And his last heart attack was about 10 years ago. The one prior to that was about 25 years ago. So those stents that he has placed in his coronary arteries has allowed him to live several more years. So that's what that procedure looks like. Some causes of chest pain. So just because you're having chest pain doesn't mean that you're having a heart attack necessarily. There's a lot of different causes of chest pain. Although I don't want you to sit there and deny the pain, I want you to go to the hospital and find out why you're having the chest pain, because it could be that you're having a heart attack. So the most popular cause of chest pain is usually heart related. And it could be a heart attack, which is a myocardial infarction, lack of oxygen to the heart tissue, which can lead to tissue death of the heart muscle. Angina, which is the technical term for chest pain, or the medical term for chest pain. Some people have unstable or stable angina. Aortic dissection is where the aorta that pumps the blood out to the rest of the body starts to actually dissect. It starts to rupture and leak into the chest cavity, and you can bleed to death from an aortic dissection. And this could be from trauma too. I've gotten called to motor vehicle accidents with unrestrained passengers, who usually drivers who don't have a seatbelt on, who have had a very hard frontal impact with their motor vehicle and have dissected their aorta and have bled out to death. So that can be from trauma as well. Pericarditis, your heart is surrounded by a protective layer called the pericardial sac, and you can have inflammation of that pericardial sac causing chest pain. It could be digestive issues, heartburn. A lot of us, I'm sure, experience heartburn. I have really bad acid reflux, and so heartburn is not fun for me when it flares up. And you can also have it from swallowing disorders, because of your esophagus, right, starts at your mouth and goes down to your stomach. And when that's esophagus, which is a hollow muscular tube, is inflamed, it can cause pain in the chest cavity. Your gallbladder, your pancreas, right? When you have gallstones or a gallbladder attack, it's high up epigastric pain. It's very high up and it feels like chest pain. So that can be mistaken for a heart attack as well. Muscle and bone causes of chest pain, costochondritis, which is inflammation of the costal cartilage. So you have your sternum, which is your breastbone, and attached to the sternum on either side are little tiny pieces of cartilage where the ribs attach, and those can become inflamed. Sore muscles, maybe you went to the gym, lifted too many weights, and you have some chest pain. Injured ribs can cause chest pain. Lung related would be your pulmonary embolism, where you have a clot that went to your lung, causing difficulty breathing, shortness of breath, or chest tightness. Pleurisy, which is inflammation of the lining of the lungs that can come along with pneumonia or respiratory disease. Collapsed lung can be spontaneous. I had a friend who was very tall and thin, and every once in a while he would get a spontaneous collapsed lung, and he would have chest pain right away. Pulmonary hypertension as well. This is an increase of blood pressure in the pulmonary artery, in the pulmonary veins, and the pulmonary capillaries. There's actually 5 types of pulmonary hypertension. They can all cause chest pain. And then other, we call them 2, idiopathic, if we don't know where the chest pain is coming from, but a panic attack. And shingles is actually in there because shingles inflames the nerve endings. And my stepfather, who I told you had 2 heart attacks, has also had shingles, and he had it around his chest cavity, around his whole torso, and he had terrible chest pain with shingles when he had it. So a lot of different reasons why we may experience chest pain. All right, so men and women differ greatly when they're having a heart attack. So men, it's usually in your face. Their signs and symptoms are just, you can't miss them. Most males that I've picked up who are having a heart attack tell me that they feel like they have a boulder sitting on top of their chest or an elephant sitting on top of their chest. They usually have pain radiating down the left arm into the left jaw. They're usually sitting there profusely sweating, or what we call profuse diaphoresis. They're vomiting. It's just, you can't miss the symptoms. Women, on the other hand, we're a little weird when we're having a heart attack. We kind of dismiss it as epigastric pain or acid reflux. Most of the women I've picked up in my career having a heart attack are just complaining of a little bit of epigastric pain. And sometimes that's it. I get epigastric pain all the time. And so sometimes I wonder if I'm having a heart attack. But epigastric pain, high up, just under the rib cage. Sometimes we get pain in between our shoulder blades in the upper back. And sometimes we think it's muscular pain, but that could be a sign of a heart attack in a woman. And the weirdest case I ever had was in a dental office. It was a woman who went to the dental office thinking she needed root canal. And the dentist ended up calling 911 for her. And when we arrived, she was laying in the dental chair, pale, a little sweaty, and she was just holding her upper jaw on the left side. And I started talking to her, and I didn't like the way she looked. I put on the ECG leads, and sure enough, she was having a full-blown heart attack. And her only complaint was pain in a tooth in her left upper jaw. That was her only complaint. So women, we are a little bit different. And heart disease, unfortunately, is the #1 cause of death among women. And we tend to want to take care of everybody else and put everybody else first. And I'm going to play for you a little bit of the video that I think is a little entertaining, but it would probably be me if I was having a heart attack, but I'm sure some of the women out there listening to this can relate to this video.
It started out like a totally normal day.
Mom!
Okay, move objection deadline to the 3rd line after survey. Oh, honey, for when you always use the verb start. breakfast?
Ow.
Whew. Don't hit your brother. Honey, you have to eat something. Here. Okay, 5 minutes to carpool. Where's my coffee?
You okay, Mom?
Oh, I'm fine. Sandwich orders. What do you want?
Almond butter and jelly.
Spaghetti.
You sure you're okay?
I'm fine, sweetie.
I am so late. Hey, buddy, how you doing? Hey, honey. You okay?
Yeah, I'm fine.
You sure?
Oh, yeah. Here.
Acai, my favorite. See you guys later.
Wear your shoes. Put your shoes back on, please. You know, go help your sister. We're going in 3 minutes. Oh my God, what am I doing? I forgot to cut off the crust. Voila. Shoes on, potty if you need it. Honey, get your sister. Okay, get her. Nobody move. I'm getting a dustpan. Oh.
Mom! I think you're having a heart attack.
Honey, do I look like the type of person who has a heart attack? Just gonna sit down. I'm totally fine. Don't forget to wear the high socks with the shin guards.
Forget about the shin guards, Mom.
Come on, Mrs. Underdog is not gonna wait. Whoa. Okay. 9. 1. Hi, sorry to bother you. I think I might be having a little heart attack. Nothing really, just some nausea, tightening of the jaw, dizziness, shortness of breath, muscle pain, achiness, this terrible pressure in my chest. Oh, really? They can be here in how long? 2 minutes. Can you make it 10? I thought I had gas. Turns out I was having a heart attack. Heart disease is the #1 killer of American women. So now I take care of my heart and I tell the women in my life to do the same.
Sounds great, by the way.
That's nice, sweetie, but that's not my heart. That is. Make it your mission to save your life and the lives of the women you love. Find out more from the American Heart Association at goredforwomen.org.
So I thought you'd find that a little entertaining. I think most women are like that, right? We kind of ignore the symptoms and just try and finish cleaning up the house and get done what we need to do. But that's the wrong thing. So if we're having signs and symptoms of a possible heart attack, we need to call 911 and call emergency services right away. So what are the actions to take? First of all, don't deny the pain, because that's what we tend to do as humans. We tend to sit there and say, you know what, I don't think this is really chest pain. I don't think this is a heart attack. Let me wait and see if this goes away. And a very sad statistic came out during COVID last year. Normally, under normal circumstances, only about 50% of people who are having heart attacks arrive to the hospital by ambulance. During COVID, when COVID broke out last year and this pandemic started, more people were waiting at home, denying the symptoms, waiting for the pain to go away because they didn't want to go to the emergency room and be exposed to COVID. So they sat there and waited out the symptoms and died at home. And so that 50% went up tremendously. And more people have been dying at home from heart attacks and strokes than ever before because they don't want to go to the emergency room because of COVID. And that's very sad. So you need to go to the emergency room and get checked out right away. Don't wait for the pain to go away. Call 911, emergency services here in the US. If you travel abroad, there is an app for the Apple phone. It's only for iOS, it's not for Android. And it's called Trip Whistle Global SOS. I put it up on the screen so you can see it. And this is an emergency app where you can access ground emergency services from anywhere in the world. Only the USA and Canada use 911. Panama City also uses 911. And there are some countries in Europe that are starting to adopt 911 also. for their emergency number, but other countries around the world use different numbers for you to call an ambulance. So Trip Whistle Global SOS not only gives you the ground emergency number for countries all over the world. I tell it to my clients at work because my clients travel all over the world, but it also has an emergency component to the app as well. So let's say you're in Madrid, Spain, and you witness somebody getting hit by a car and you need to call an ambulance. You just type in the city Madrid. This little circle appears above the city, and if you tap it on, it will dial an ambulance for you and send it to your location. It will ping the GPS in the GPS settings in your phone and will send an ambulance to you. So it's a great app for those who travel internationally. Don't drive yourself to the emergency room, only if it's a last resort, because you could have an accident behind the wheel. You could pass out on the way to the emergency room. If a loved one's driving you, if you go into cardiac arrest in the car, they're then going to have to pull over, call emergency services. And this has happened to me before as a paramedic, where somebody was trying to drive somebody to the hospital. They went into cardiac arrest in the car, and we had to go to wherever the car pulled over and then take care of them on the side of the road, which is dangerous for everybody, and get them to the hospital as quickly as possible. If you have no allergy to aspirin and you have no contraindications to taking aspirin, chew either 4 chewable baby aspirin right away, or 81 milligram baby aspirins, or 1 adult aspirin, which is 325 milligrams. So either one or the other, don't do both. Aspirin is not a blood thinner. Aspirin is a platelet aggregator, meaning it tells the platelets in the bloodstream to keep flowing during the possible time of a heart attack, because the job of the platelets is to clot. So when we have a cut on our arm, the platelets rush in to stop the bleeding. But during the time of a heart attack, we want to keep that oxygenated blood flow going through the coronary arteries. And so we want to tell the platelets, don't clot right now, just keep flowing. And that's why we take aspirin during the possible time of a heart attack. And you want to make sure that it's not enteric coated. Enteric coated aspirin is going to take a lot longer to break down into your bloodstream. So try and take aspirin that has no coating on it. Enteric coated aspirin is for aspirin that you're taking every day as a preventative, or aspirin that you don't want to erode the lining of your stomach because it's very acidic. Have available to emergency services your past medical history, your medication list, your allergies, your emergency contact. A lot of homes I've gone into, I've seen the vial of life, where they have a list on their refrigerator. And for those of you who have an iPhone, if you want to grab your phone real quick, there's an app on the phone, and it's called Health. I'm going to hold it up to the camera so you can see it here. It's white with a red heart. It looks like this. It's called Health. And if you go into that Health app, there is a medical ID section to that app that you can fill out for emergencies. Apple put this on the phone for emergencies, and you cannot delete this app off the phone, by the way. If you go into that Health app and find medical ID, I want you to create a medical ID in that Health app and fill it out. You can put in your medications, your allergies, you can put in your emergency contact information, your blood type, if you're an organ donor. And the great thing about it is most lay people, first of all, don't know what I'm telling you right now about this app. As a paramedic, I've used this app to gain access to this critical information when nobody's there to tell me anything about that patient. If I hold in my on-off button and my top volume button at the same time, so I'm going to hold in my on-off button and my top volume button at the same time, this is the lock screen of my phone. And right there in the center, it says medical ID. All right, so this is a lock screen, and right there in the center, it says medical ID. And if I slide that over, it goes right to my medical ID information. And it doesn't go anywhere else on my phone. So if I'm alone and something happens and I don't have a way of telling the EMS or the emergency room, what's going on, they can access it from my phone, and they can't go anywhere else on my phone. So they can't see text messages or anything else. If you go to the lock screen of the phone, that looks like this. Down in the corner, it says emergency. If I tap that on, it says medical ID right here in little tiny red letters. If I tap on medical ID, it goes to the same place. It goes right to that medical ID. So this can be accessed from the lock screen of your phone as long as you have it filled out. And if you know somebody who's got an Android, there is medical ID access on Android as well that does the same thing where you can access it from the lock screen of your phone. So I wanted to share that with you because that is life-saving information. And as a paramedic, it has helped me out tremendously if I have access to that information. All right, so who is vulnerable to having a heart attack or heart disease? And this map shows by county where the most preventable death rates occur. And so unfortunately, we're in the dark green, which is not good because that actually means we have the power of holding the most preventable deaths, but we also have in the South where we live some of the highest causes of death from cardiovascular disease as well. And some of that is socioeconomic, some of it's family history. We're going to talk about modifiable and non-modifiable risk factors here too. And this is also showing who does cardiovascular disease affect the most. And unfortunately, it does affect African Americans the most. They're most vulnerable to heart disease. And it usually starts young. That buildup of plaque usually starts very young with African Americans. We're not sure why. It could be family history related as well. But unfortunately, that is the culture that's hit the hardest with cardiovascular disease. They have, according to the CDC, the highest morbidity and mortality rate. And out of all the causes of death, cardiovascular disease is still number one. Cancer is number two for causes of death. Unintentional injuries is number three, and chronic lower respiratory disease is number four in the United States for causes of death. So let's look at modifiable and non-modifiable risk factors. What does this mean? What can we change and what can we not change about cardiovascular disease? And so there's a lot of things we can't change, unfortunately. Unfortunately, our age has a lot to do with it. So if you're over 65 years of age, 80% of people who die from cardiovascular disease are over age 65. So as we grow older, our arteries are under high pressure every day, pumping blood out to the rest of our body. And we abuse our arteries. I know I've put on weight since I moved down here to the South with all this Southern comfort food, and everything's fried down here. And I love fresh shrimp. I'm eating fresh shrimp all the time, which is high in cholesterol. It's low in fat, but high in cholesterol. So, you know, that has a lot to do with it too. Gender, primarily, it's still higher in men, but women are catching up, ladies. We're under high stress with our jobs. Some of us are smokers, obesity, all different factors that have allowed us to catch up to men with heart disease. Family history is a non-modifiable risk factor. So if you have a relative who developed heart disease before age 55, your risk has increased as well. And then again, race. On African Americans, Hispanics, and Latinos, Native Americans usually have a higher risk of heart disease. So what's the good news? Because I've given you a lot of bad news here. I'm going to give you some good news. What can we change, right? So we can exercise, because we know that exercise relaxes the arteries and it brings more oxygenated blood supply to the heart muscle. Exercise also raises our HDL, which is our good cholesterol. LDL is our bad cholesterol. HDL is our good cholesterol. So you want to get that HDL up. And also, we want to get our stress level down. Get a good night's sleep. If you regularly get less than 6 hours a night, your risk of a heart attack actually doubles. We also know that insomnia has been linked to increased irregular heartbeats and hypertension. Sleep apnea also is attributed to heart problems because we actually stop breathing in the middle of the night with sleep apnea. Eat less sugar, more vegetables. 1 can of soda a day can increase the risk of a heart attack by 20%. That's pretty significant. And sugar damages our arteries and our organs. And it also lowers our good HDL. It lowers our good cholesterol, which is bad. Find your zen, right? Too many stress hormones can constrict your arteries. So especially in women, stress can trigger spasms in those tiny little arteries around the heart and can harm the heart over time. So try to relax when you have the opportunity to, and stop smoking. After the first year of no smoking, your risk of heart disease actually decreases by 50%. That's really significant. So some things that we can do to change our daily lifestyle to lower our risk of cardiovascular disease. All right, number 1 cause of cardiac arrest is cardiovascular disease. We know that, and it usually comes from the electrical system in our heart producing an abnormal rhythm because of that cardiovascular disease. What else can cause cardiac arrest? Drownings, somebody who's choking and we don't get it out of their airways soon enough and they stop breathing. Drug abuse, illicit drug use, severe injury to the chest cavity, brain damage. Once we stop breathing, eventually our heart will stop beating. Electrocution, that's pretty obvious. Lightning strikes. I've taken care of people from lightning strikes. We do what's called reverse triage. So we want to get the AED on them right away to reverse that electrical damage to the heart muscle. And we also know that once we lose enough blood, we lose oxygen through the hemoglobin. So if we're bleeding into our abdominal cavity or chest cavity or bleeding out externally, we can go into cardiac arrest and electrolyte imbalances as well. I wanted to share this quick news clip. It's there was a man in Tucson, Arizona, who actually saved somebody's life doing CPR that he learned from the episode of The Office. Don't know if anybody saw that episode of The Office. It was quite entertaining.
Well, the Arizona Daily Star reports that a Tucson man saved a woman's life using a CPR lesson that he learned watching the TV show The Office. 21-year-old Cross Scott saw the woman slumped over her steering wheel in her car, and he broke the window to get in. Scott had no CPR training, but this episode of The Office came to his aid.
Good trick is to pump to the tune of Staying Alive by the Bee Gees. Do you know that song?
Yes, I do. I love that song. First I was afraid, I was petrified.
No, it's Staying Alive.
Okay. Staying alive, staying alive. Staying alive, staying alive.
Well, you can't tell by the way I use my walk. I'm a woman's man, no time to talk.
That's actually really clever. So using these tips, Scott was actually able to revive the woman. Even though the episode could be a tutorial of what not to do, medical experts say that pumping to the tune of Staying Alive is actually useful. It establishes the rhythm of chest compressions.
I thought that was pretty funny, but so yeah, that's the tune actually that we use, is to Staying Alive. We have to speed it up just a little bit because now we're doing cardiac compressions at 110 a minute instead of right at 100 a minute. So, but that's the tune that we want our compressions to go to. So why is it important to know CPR? I've been teaching CPR for 30 years with the American Heart Association. I'm a huge advocate of everybody knowing CPR and having AEDs available to them because we know that this can work to save a life. And it's really not up to us on who lives or dies that day. It's not up to us at all. But we have the power of potentially changing a critical situation for the best. So 7 good reasons why. You have the power to learn CPR. It's very easy to learn. And the majority of cardiac arrests, by the way, happen in the home. 70% of cardiac arrests happen at home. So if your loved one knows CPR, you have a better chance of surviving. CPR makes automated defibrillators more effective. So once we get the blood flowing throughout the the whole system and we apply that automated defibrillator, it has a better chance of shocking if we can get the blood flowing and getting the organs oxygenated. For every minute that we waste, that we are not doing CPR on that cardiac arrest victim, increases their chances of death by 10% for every minute that goes by. And that's pretty significant because it might be 10 minutes until the ambulance can get to your house. In that 10 minutes, you can be doing compression-only CPR, keeping the blood flowing continuously until that ambulance arrives. And they'll have a better chance of not being brain dead too at that point. Bystander CPR can quadruple a person's odds of surviving sudden cardiac arrest. That's pretty significant. And this is sad. Less than 5% of the American public is trained in CPR. The state of Washington has the highest amount of people trained in CPR. It's been said that if you're gonna have a heart attack and go into cardiac arrest, do it in Washington state, because there's more people up there who know CPR than any other state in the nation. New Jersey, where I came from, they made it a requirement in high school to have CPR classes in high school. So everybody graduating high school in New Jersey has to have CPR training, which I think is so important. So what happens in cardiac arrest? The most common cardiac dysrhythmia is called ventricular fibrillation. This is when the heart is just quivering. So normally our heart is pumping blood 60 to 90 times a minute, it's pumping away. And then either because of cardiovascular disease or trauma to the heart or any of those other causes that I mentioned, our heart can go into what's called ventricular fibrillation, where the heart is no longer pumping, now it's just quivering. So it's sitting in the chest cavity and it's just quivering like this. And this is what it looks like on ECG. I'm just going to play a small part of this.
So this patient's in sinus rhythm at the moment. Let's just keep an eye on it there.
So this is a normal heart rate. This is what a normal ECG looks like. And here goes the heart. It's going into ventricular.
Now, the patient's now gone into ventricular fibrillation. And in ventricular fibrillation, there's fast. The machine's alarming to tell me. That's good. I had noticed. So in ventricular fibrillation, there's fast, chaotic, uncoordinated contraction of areas of the myocardium. Different bits of the myocardium doing its own thing. It's twitching and quivering. And in this rhythm, there's no effective cardiac output. The blood pressure is going to be 0. Now, the causes of this can be ischemic heart disease, such as myocardial infarction, severe or congenital heart disease, electrolyte imbalance, rapid changes in the levels of potassium or calcium in the blood, for example. Could be electrocution, severe hypoxia. And we notice the rhythm's irregular with poorly formed wide QRS complexes. And I would certainly classify this as a coarse ventricular fibrillation. But because we're not treating it, it'll become finer over time. We'll get a finer ventricular fibrillation.
So I'm going to stop it here, but what happens is eventually that goes to a fine line and they go into asystole, where the heart has no electrical activity left in the heart muscle at all. And we cannot shock flatline or asystole. There's no electrical activity left in the heart muscle for the AED to work with. So I know on TV, they shock flatline all the time on TV, and that's wrong. In the medical field, we never shock a heart that's flatline. We continue doing good CPR, and we try to figure out the causes as to why this person went into cardiac arrest, but we do not shock a heart that's flatline, and we don't shock a heart that's in a normal rhythm. Ventricular fibrillation is the most common cardiac dysrhythmia we see in adults. So what do you do if you're faced with a situation where a loved one's in cardiac arrest or you witness it in a public place? Recognize what's going on right away, right? You have some knowledge now to recognize cardiac arrest is when they're unconscious and they're not breathing. Or they might be laying on the ground gasping for breath, and gasping is not normal breathing if they're only gasping a couple times a minute. You want to make sure the scene is safe before you approach the victim. You want to try and wake them up, tap them on the shoulders, shout in their ear, make sure they are unresponsive, and then we open up the airway and we look for breathing. And you know, hopefully at some point you're going to take a CPR class, whether it's here at Hampton Hall or outside in the community. This isn't a CPR class, but I just want to give you some idea of what to do. You want to make sure you've called for help, and if there's an AED around in the adult, if you're alone, get the AED first, because you only have a 10-minute time window in which to apply the AED. So I'm just gonna forward through this video here. They go back into a fine line and then back into VFib for a little while. So it gets kind of crazy. All right. I can get
Machines alarm killer.
Hold on a minute. Stand by here.
Effective.
For some reason, my computer's not advancing.
Cardiac output.
All right, here we go. So I wanted to show you this quick video on what to do if you're faced with cardiac arrest as a bystander. Bystander CPR, compression only CPR. Right now, especially during COVID, I would not be breathing into anybody. I would be doing compression only CPR, especially during this pandemic. And we know there's a lot of benefits to doing compression only CPR. We're keeping the blood flowing to the brain and heart where it's needed the most. So I'm going to show you what that looks like, compression only CPR.
If you see a teen or adult suddenly collapse, it's important to act fast. Helping to save a life is easier than you might think. Just start hands-only CPR. The first step is to send someone to call your local emergency response number or call it yourself. Then get directly over the victim. Put the heel of one hand in the center of the chest, then put your other hand on top of the first. Then push hard and fast in the center of the chest until help arrives. It's important to push, giving 100 to 120 compressions per minute, which is about the same tempo as this song.
That's what compression only CPR looks like. You want to do that until EMS arrives, until help arrives. Keep that blood flowing to the heart and brain. We have about 20 to 30 minutes of oxygen reserve in our body, in our red blood cells once we die. So if we can keep that blood flowing to those vital organs, that is going to help with our survival rate and help to avoid brain death.
CPR. Call arrives.
We're going to have to call for help again in case they didn't come. All right, let me move forward here. We're just about done, so bear with me here. What are good mechanics of CPR? Compressions. So after you have established that the scene is safe and this person's unresponsive and you've called for help and you're starting compressions, we've opened up the airway, we've checked for breathing for no more than 10 seconds, and we start compressions right away. You got to have good body mechanics to make this work, because you're compressing the heart between the sternum and the spinal column at a rate of 110 compressions a minute. That's pretty fast. So you have to go down about 2.5 inches in depth to accomplish pumping the heart, because their heart has stopped. So now you're mechanically pumping the heart. And this is what good compressions look like. So your hands are in the middle of the chest, in between the nipple line. And you want your depth to be at least 2 inches in depth. So what you're doing is you're squeezing the heart, emptying the blood out. And when you come back up with your compressions, the heart is refilling with blood. And we call that chest recoil, when the chest comes up to its natural position. And your rate should be at 110 a minute. To pump the heart, to get this blood flowing continuously through good compressions. What do the mechanics look like? So you want your shoulders over the victim. You want to lock your elbows, and you're basically rocking from the hips as you're doing these compressions. It's all coming from the hips. And it's difficult. I have all my students do 2 continuous minutes of CPR compressions. And after 2 minutes, you would have think I had them doing it for 10 or 15 minutes. They're exhausted because you're really pressing down hard with each compression. And you're in 2 minutes, you're doing 220 compressions in 2 minutes. So it's pretty fast. It's not easy to do. It takes a lot of effort. All right. Oh, my computer's giving me a hard time today. So I think this is the most important slide you're going to see. And I'm just about done the presentation. So I'm sorry we're running a 5 minutes overtime here. I call this the time of the essence slide. So if someone goes into cardiac arrest and we apply an automated external defibrillator and it finds a shockable rhythm. So it finds that ventricular fibrillation where the heart's just quivering and it shocks in the first 2 minutes of collapse. Their chances of surviving are 90%. If we can catch that shockable rhythm in the first couple minutes of collapse, they have a good chance of surviving. If you wait 4 minutes to apply the automated defibrillator, the automated external defibrillator, and it finds that VFib and it shocks, the chances of survival are already down to 40%. That shockable rhythm, and the AED doesn't tell you what rhythm they're in, it just looks for a shockable rhythm. And there's actually 3 possible shockable rhythms, but the most popular is this ventricular fibrillation. If you wait 10 minutes to apply the AED, look at their chances of survival after 10 minutes. It's less than 3%. And so you have about a 10-minute time window from the time that person collapses in cardiac arrest to apply the AED and have it shock. Because after 10 minutes, the heart will stop quivering and it will go to flatline. And an AED will not work on a heart that's in flatline or asystole. So you have a very short time window in which to apply that AED and have it find a shockable rhythm. You cannot use an AED if they're laying in water. So if you pull somebody out of a swimming pool in cardiac arrest, the surface has to be dry, and you have to dry off the chest wall before you turn the AED on and apply the pads. You can use it if they're laying in snow. I've shocked people in the snow. You can use it if they're laying on metal, and you can use it if they're laying on grass. We do on the grass. They cannot be laying in a big puddle of water. Water and electricity, as we know, don't mix too well. At Hampton Hall here, we have Zoll AEDs. And I've been talking to Christina and Lorraine about training the staff here and getting AED prep kits into the cases with the AEDs, because when you go to apply an AED, you have to open the shirt and you have to bare the chest in men and women. And so these AED prep kits have scissors in them to cut off clothing and razors to shave excessive chest hair, because before you put the pads on, there cannot be any metal near the pads, near the pad placement. You should not be putting the pads over any type of electrical devices such as an implantable pacemaker. And you have to remove any medicine patches that you see from below the neck to above the belly button. And this is all that you learn more in a CPR class, but there are some rules with the AED. You should not have the pads near any type of metal at all, or the electricity will arc. So these are the Zoll AEDs that we have here at Hampton Hall. There's lots of brands of AEDs on the market. Philips is a big maker of AEDs. Heartbeam, the ones that my pilots carry on their corporate jets are Heartbeam 450p Samaritan pads and the Philips Heart Start. You can buy AEDs for home use, although the only one that's been approved for home use has been approved by the FDA, is the Philips Heart Start. So before you go on Amazon tonight and purchase an AED for home use, make sure you go on the FDA website and buy an approved AED that's been approved by the FDA. This is my last slide. I'm going to show you this real quick. This is how to use the AEDs that are here in Hampton Hall. And AEDs are made on a 4th grade level. So anybody should be able to take these off the wall, turn them on. And that's the first thing you do, by the way, when you get an AED, is that you turn it on and you're just going to listen to it. And it's going to tell you what to do. They're that simple to use.
CPR alone won't restart a heart. It keeps the victim alive until an AED and medical help arrives. Most importantly, an AED should be used as quickly as possible. Survival can depend on it. An AED, or automated external defibrillator, is a portable, user-friendly medical device used to treat someone in cardiac arrest. It's designed for use by lay rescuers without medical supervision. That's you. An AED will automatically diagnose abnormal electrical heart activity that causes cardiac arrest. An AED treats cardiac arrest by delivering an electric shock to the heart called defibrillation. This stops the abnormal electrical heart activity and allows a chance for the heart to function normally. The AED analyzes the heart's electrical activity through electrode pads applied to the chest. Defibrillation provided by an AED is highly accurate and effective, but you have to act quickly. Since most of us, fortunately, don't run into these situations every day, modern AEDs have CPR feedback technology and are recommended by the latest international resuscitation guidelines. They provide real-time feedback for depth and rate of chest compressions, which allows rescuers to know how well they're performing chest compressions. It guides rescuers with prompts and a real-time bar gauge to the recommended depth and rate of chest compressions set by the International Resuscitation Guidelines. Remember, doing CPR and using an AED are both critical in a sudden cardiac arrest.
All right, so that's the use of the Zoll
In our next
that we have here. Let me get past this. And we're done. I wanted to thank you for your attention tonight. I hope you learned something from the presentation. And you can find me in the member directory. Some of you know me already. If you have any questions or concerns, feel free to contact me. And I'll take any questions now if any of you have questions.
That was so informative. Thank you so much. And that was, we know how much work you put into that. And that was so informative. And I definitely think it would be really awesome if we all got CPR trained. Mr. Spears is asking where the AED is located in Hampton Hall. You just kind of checked all of ours out. Do you want to? I know we have one at Fitness and one in the community clubhouse here in the hallway.
Yeah, there's one outside of the dining room, also in the hallway there. And like I said, I've been talking to Lorraine about making sure that the staff is fully trained in CPR and choking. And we have, some elderly population in here as well. And you don't have to be elderly to have a heart attack. We know that. You can have a heart attack in your 40s or 50s, especially if you have a family history. So yeah, there's one outside the dining room. There's one in the fitness area. And I have to see if there's one over near the pool. I'm not sure if there's one in the pool area, but there should be one in the pool area as well.
We have a lot of people just thanking you. This is a great presentation, gave us much information. Mr. Rambo wrote that. Mr. Downen, I just want to say thank you.
Oh, you're welcome. You're very welcome.
And
it's important information. Don't underestimate what you learned tonight, because you might use it one day. And I hope you never have to use it, but it's good information to know. So it was my pleasure. Any other questions?
thank you for such great information. That was Mr. Neal. Mrs. Halpern says, great job.
Thank you. My pleasure. Hopefully I've inspired you to take a CPR class.
Mr. Mitchell asked if we have one in the golf shop or Pete's, and I do believe there is one over there.
Yeah. I don't know if there's one over in the golf shop. There might be, I think there might be one outside of the restroom area. But I think what we need to do is really map them out, make sure we have one all in appropriate areas, because there also should be one that we can kind of grab and go, that could be taken out to the golf course as well, because that's going to be a delay in administration of that AED if we don't have one that we can just grab and get on a golf cart and get out there to the golf course. That's an important thing to add to it as well.
Yeah, Mr. Sleeves agrees.
I actually wrote out a whole plan that I did show Lorraine some of my thoughts on getting making sure that we are equipped to handle this type of emergency in here. So, and the pandemic unfortunately has delayed some of the actions of that plan with training, but as soon as it's safe to resume training with everybody, I already have a plan in place to get everybody trained up properly in here. Any other questions, concerns?
Several clubs I belong have them on both nines. That's Mr. Sleece. That's a good idea. I'm not sure where they are on the golf course. But Jerry Twig, our maintenance director, he does maintain them, or he gets them serviced. So we could, Mrs. Mitchell says, shouldn't it be in the golf shop, as that is where the call would come in from the course? And I'm fairly certain there's one in the golf clubhouse that they would.
I had gone around at one point with him and made sure that the AEDs were being checked properly too, because part of the problem is some people purchase AEDs and they don't check them to make sure that the batteries are still operating in current, and they can be affected by extreme temperatures, and the batteries in most of them are only good for 4 years. So the batteries have to be changed out. So that's part of the written plan that I had put together. But I did go around with, I think, what is his name, Jerry? It was several months ago, and we checked the AEDs on the premises to make sure they were all operating in operating order.
We just appreciate you so much, and
no problem.
I'm just grateful for the information. I know everyone else is. Mr. Neal says, thanks for pointing out the importance of having emergency info on the phone. Yeah, that's really awesome.
Yeah, it's a good app. When I teach my flight crew over at Flight Safety, I tell all the pilots and flight attendants to please put that on their phone. So if they're calling in an emergency to our physician on the ground, they have that information at their fingertips. But in a public situation too, it's really a great app. That Apple did that and put that on the phone. Any other questions?
I don't know.
All right. Well, everybody have a good night. And if you need anything, you know where to find me. And I hope you never need the information. Everybody stay safe out there.
Thank you, Mrs. Reichel.
Sure. Have a good night.
Have a great night, everyone.
Bye.
Bye.